I have a daughter who's about to go into high school, and she can't think of anything worse than being a doctor, so especially being an OBGYN. So I'm always excited to talk about what I do, and so I am very grateful for you to let me be here. So a little bit about me, and again, any questions that you have anytime, just jump in. I'm a foreign medical graduate, which means that I did not graduate from a US medical school, and we'll kind of talk about that a little bit afterwards, kind of in the next slide. I graduated from medical school in 2004, which means I'm really old. Were you all born after 2004? Yeah, okay, I'm really old. I graduated residency in 2011, and I've been at Swedish since 2013, so 10 years now. I'm one of the OBGYN generalists, which means that I haven't done a fellowship. I do full scope, all obstetrics, gynecology, clinic, outpatient call, and I work at our First Health Clinic and the Ballard Clinic. I'm part of the faculty for the new Swedish OBGYN residency program, so that's how we train our OBGYN doctors. We started last year, so in July our second class started, so we now have 12 residents. And then I'm the Senior Medical Director for Women's Health Services, which basically means I do all the jobs that nobody else wants to do as far as administration is concerned. So kind of a little bit about, how to become a doctor. I'm sure that you've kind of been through this a little bit, so I'm not going to go through it a lot. Obviously, you need to go to medical school in order to be a doctor. There's the traditional path, which is, doing a 4-year college degree, like an undergrad, and then going on to medical school. So this is actually not my path. I did medical school in the UK. And in England, medical school is actually an undergraduate degree. So I have a Bachelor of Medicine and a Bachelor of Surgery, which means that I went straight to medical school from high school at age 18. And so I was a qualified doctor by the time I was 23, which is kind of crazy. There's obviously other things that you can do. So there's some direct medical school programs that are coming up. These are becoming a lot more popular, where you basically apply for your undergrad and your medical degree at the same time. You do them all at the same place. You go straight through. The benefit is that sometimes you can complete it a little bit earlier. The average length of time is 7 years, as opposed to 8 years if you're doing a traditional undergrad and then med school. You do need to maintain a minimum GPA or and get a minimum MCAT score, so that's the Medical College Admissions Test. Otherwise, they basically will take away your medical school, kind of approval. And then, some people who are, really hardcore decide to do dual degrees. So they do their 4-year undergraduate, and then they do an MD, MPH, so Masters of Public Health, MD, MBA, Masters of Business Administration, or an MD, PhD. So those are a lot of people that want to go on to be, kind of medical researchers and do basic science and, maybe do a lot of clinical research, so you're more in the lab than rather than seeing patients. If whatever you're doing, I think that one of the things that I wish I had done and that I would actually recommend for you guys, if possible, is to consider taking a gap year, whether in between high school and college or in between college and medical school. Once you get into medical school, you're busy all the time, and then you get into residency and you're even more busy, and then you get into attending life, and then it's just miserable, because then you have a mortgage and bills and you're paying back your student loans. And so, kind of taking some time to really figure out what you want to do with your life. And just to kind of have some enjoyment, I personally think is really important. And then foreign medical schools. So I don't know if you've heard anything about this. I came from a really good medical school in England. It's not Oxford or Cambridge, but it was one of the really good medical schools when I went. But because I hadn't done my medical education in the US, I was considered a foreign medical graduate, the same as anybody else from any other country, people that don't speak English as their first language. So I had to do all of my medical school education. I had to do all of my exams in medical school, and then I had to do all the same exams that US medical school grads do. And I can tell you that being an OBGYN, this past cycle, for people that were matching into OBGYN residency, 20% of US medical graduates did not match. And it was closer to 50% of non-US medical graduates didn't match. So if you really want to practice medicine in the US, it's really better to go to medical school in the US. And one of the things is that there are some medical schools, like in the Caribbean, which are considered, they tout themselves as American medical schools, but they're actually not, and you have to do the exact same thing. And a lot of them are for profit, meaning that, it's much, much easier to get in, but they don't give you anywhere near as much support, and they don't give you anywhere near as much financial support, and you might not be able to qualify for federal student loans. And so it's much, much more expensive. And so that was kind of the big thing that I just wanted to put out there for medical school. A little bit about getting into medical school. If you guys are thinking about it, again, I'm sure that you've, reviewed this before, but there's the American Academy of, I think it's American Academy or American Association of medical colleges, core competencies. So these are things that they're looking for in people that are applying for medical school. Obviously, you have to have a certain amount of, academic achievement. So you have to, get a good GPA, you have to get a good MCAT, the school that you go to for undergrad, if you want to go to Harvard for medical school, and you probably need to go to a pretty good, undergrad school in order to be able to get in as well. You have to do a certain amount of extracurricular activities, and that might be things like shadowing, different doctors and, different things, doing community service, volunteering at different places. Unfortunately, a lot of medical schools and especially residencies are looking for you to have done some form of research, so kind of getting in the lab and getting some research. And then, really, your personal qualities of, leadership, and, you need to show that you have good communication skills. You're going to be talking to people all day, every day, from all different backgrounds, from, different religions, people that don't speak English. You have to be able to explain things to them. And I think that this is, personal qualities is probably the most important part. And then, so this is why a lot of people think about foreign medical schools, because of how hard it is to get into the US, but again, don't do it. So what's an OBGYN? Well, there's kind of lots of different definitions, and there's lots of different things that people think about. So, women's health physician is kind of one of the big things. So ACOG, the American College of OBGYN, touts itself as that we're women's health specialists. And I think that, unfortunately, medicine doesn't catch up with, society as quickly as what we would like it to do, because obviously there's a lot of people that don't consider themselves women, who may have a vagina, who may have, reproductive organs. And I do a lot of, gender-affirming healthcare. And then it's I could literally talk for hours about, what is a woman, because there's, genetic sex, right? And the genetic sex is XX. But there's also a condition called Turner's syndrome, which is where you only have one X chromosome. And so are you not a woman? Are you a woman? There's XXY, which is, you have a Y chromosome. So are you a man or are you a woman? You have two X chromosomes. There's your internal reproductive organs. There's your external reproductive organs. There's all sorts of things that can change. And then obviously, there's, how you feel and your gender identity inside. So I think that it's, we're physicians and surgeons, for people with, a specific characteristic of reproductive organs, which is a little bit more of a mouthful. A lot of people consider us primary care doctors. So a lot of, women or a lot of people who identify as women, are, they only go to see an OBGYN for their primary health care. And so I get people coming in and asking me about their cough and about their, sore throat, and I'm like, I have no idea anymore, right? I am like far too far removed about that. But I do a lot of primary health care. I manage people's thyroid disease. I, talk to people about their cholesterol. I talk to people about, like healthy eating and exercise and, how to make sure that they don't have a heart attack as they get older. And most insurance companies, there's a type of insurance called a HMO, which is a healthcare managed organization, which is where you have insurance and you get assigned a primary care doctor, and you're not allowed to like just choose a specialist. If you have to go and see a specialist, then your primary care doctor has to refer you. And even HMOs say that, all of those people can pick a primary care doctor and an OBGYN. So, a lot of people, including insurance companies, consider us primary care. We're also specialists, and we'll talk about some of the, fellowship training that you can do and become really highly specialized. And I think that the longer you've been out, a lot of the time people find like a niche or something that they're super really interested in, and that's what they want to spend the majority of their time doing. One of my partners who joined as a general OBGYN, so she was, delivering babies and, doing surgery and seeing patients in the office. All she does now is like infectious disorders of the vulva, so that's the external, part of the reproductive organs, and sexual pain. That's literally all she does. And she is booked out 9 months for people to see her. So there is like you can get really, really super specialized within this if you want. We're definitely surgeons. I operate every week. I operate on ovaries, on fallopian tubes, on uteruses, on vaginas, on vulvas, on pregnant uteruses. Being a surgeon is definitely a huge part of what we do. Emergency physician, so there's lots of emergencies. So we have, at most of our campuses for Swedish, we have what's called an OB-ED, or an OB emergency room, which is anybody that's pregnant above a certain number of weeks. If they're having an emergency, instead of going to the regular emergency room, they come to us. And so, we've diagnosed people with blood clots in their lungs. We've diagnosed people, with gallstones. We've diagnosed people with, just normal back pain, similar to, what you'll get as an emergency doctor if you're working in the ER. Trauma surgeon. Fun fact, I don't know if anybody knows, do you know how much blood you have in your body on average? How much? Okay. So, awesome. So you have about 50% more when you're pregnant. And at term, the uterine arteries, so the main blood vessels that go to the uterus, pump 1/2 liter of blood a minute. So if you have something that goes wrong with your uterus, like, you tear into your uterine artery, you lose 1/2 liter of blood a minute. So you will lose your entire blood volume in less than 10 minutes. Right? And so, it's not unusual, unfortunately, in some really complicated settings that I'm like transfusing people like 10 units of blood like in a time and doing like emergency surgery and sending them to the ICU. So you cannot be afraid of blood if you're going to be an OBGYN because you will see a lot of it. And I tell people all the time, right, at no other point in your entire life do we say that it's normal for you to lose up to 1 liter of blood, and that's just like fine. That's like not a problem. And that happens every single time somebody has a baby, is that we say it's normal to lose up to 1 liter of blood. And then baby catcher. So half of the time of what I do is delivering babies, which is one of the most enjoyable, is one of the funnest part of my jobs, and also one of the most terrifying part of my jobs as well. And we can talk about that, and that's the thing that all people are always really excited about and really excited about seeing. So to be an OBGYN, after you finish medical school, you go to an OBGYN residency, and the residency is 4 years. So it's 4 years undergrad, 4 years of medical school, and then another 4 years before you're a qualified OBGYN. A lot of people will go out, finish at the 4-year mark, and then decide that that's it, and they're going to be a generalist OBGYN, meaning they do all of those things that we just talked about. But some people will go on to fellowship training. And so that's, depending on what it is, it's an additional 2 to 3 years. And these are some of the recognized like fellowships that we have. So maternal fetal medicine, do you know what those are? You're like nodding your head, nope. So, yeah?
Okay, so I don't know a lot about that fellowship in like overall, but I did do a brief like research assistant thing last summer for a woman at UW who was an OBGYN with a fellowship in maternal fetal medicine, and she was doing some research on like COVID-19 vaccines and you know, like pregnant women and all of that. And I think where she did some talks on that concept.
So MFMs are like super specialized in high-risk pregnancy care. So whether it's like a really high risk because there's something going on with the baby, like there's 3 in there, which is you know, really super high risk because you know, when there's more than one baby, you know, your body has to try and adapt to, you know, feed 3 babies, grow 3 babies. They're fighting for space. They want to come out super early. And, you know, they increase your risk of things like high blood pressure, which can potentially cause strokes. They increase your risk of things like diabetes, which can cause all sorts of problems. They also take care of people who are pregnant who are high risk because of their health problems. So like if somebody's had like a kidney transplant or if somebody's had like a heart attack in the past, you know, it's the maternal fetal medicine doctors who take care of those patients. What about urogynecology? Or it's also female pelvic medicine and reproductive surgery, reconstructive surgery. Do you know what uro stands for, urology? It's okay, there's no wrong answers. You're here to learn. Yeah, what do you think?
Is it more specialized in like specifically men? Is it urology like men's?
It's men and women, but there's a more predominance
Yeah.
of uro issues in men.
So uro is anything to do with the urological system. So like the bladder, a little bit about the kidneys, but the ureters, the tubes that go from the kidneys down to the bladder, and then the urethra, which is the tube that's going from the bladder out. And so these are doctors who specialize in things like, you know, if you leak urine when you cough and sneeze, or if you, like, you know, tear, like when you're having a baby and your uterus is like falling out of your vagina, because unfortunately that can happen after you've had a baby. They're the ones that fix it. So that's kind of the urogynecology is like specialized surgery in those things. What about oncology, gynecological oncology?
Is that like anything kind of typical, like a lot of like cervical cancer and things?
Yep.
Is that like anything has to do with like cancer and female reproductive system?
Yep, exactly. Yeah, so any cancers that, you know, are related to the ovaries, the fallopian tubes, the uterus, the vagina, the cervix, or the vulva, the gynecology oncologists do that. And they're super specialized surgeons. So, you know, when you're taking out, like, for example, cancer of the ovaries, unfortunately tends to spread like pretty early and we don't find it until it's already spread, and so it might be attached to like the bowel or it might be attached to like the bladder, and so the gyne-oncologists, you know, when they're taking out like an ovarian cancer, they might also do bowel resections. You know, when I was in residency and I was working with the gyne-oncologists, I took out somebody's liver, part of somebody's liver, I took out their spleen, so they do a lot of like really complex surgeries like inside the belly cavity. And then what about, so reproductive endocrinology and infertility?
That's kind of talking more about like your hormone system, and I'm guessing that's probably relating to like, I think I actually got referred to one because I have PCOS.
Mm-hmm.
So I'm guessing kind of more managing like your hormone system, hormone balances, and how that affects your ability to conceive.
Yep. And then what about the infertility part?
I'm guessing also kind of specializing in women who are struggling to conceive or can't conceive for other reasons, and finding if they want solutions to.
Yep. Yeah, so these are OBGYNs who've done like 3 extra years, and that's exactly right. So they specialize in, you know, like hormone problems that might impact your ability to get pregnant, or hormone problems that affect how your body has developed. or helping people to grow families or have a family if they want to get pregnant. And a lot of the time, the REI docs, we call it REI for short, will also deal with people that, like, it may be not me that has a problem getting pregnant, but my partner has, sperm that doesn't work. And so, they can also, help with that. So that might be, for example, like taking the sperm and injecting it into one of my eggs, which is basically what IVF is. So it's not just female infertility. It can also be, anybody that's in a relationship. We work with some really great REI doctors at Pacific Northwest Fertility, and they also have a really cool program for people who are same-sex partners. For growing their family. So there's things like donor sperm, or there's something called a surrogate or gestational carrier. Has anybody heard of those terms before? Do you know what they are? Yeah, what are they?
So surrogacy is like when it can either be like when you have, like if it's like a couple, like a male and a female, like they can use an egg and put it into the surrogate's like uterus, right? And it takes, because like it's easier for, like it can be easier for that person to deliver a baby or something. Or surrogacy can also be with like two men as well.
Yep.
And they can offer their egg or sperm.
Or there can be people that donate their eggs. Or people that, may have had fertility issues, and so they've created embryos, which is where the egg and the sperm meet together and they divide, and it's normally kind of like at a 6-cell level. And then they freeze them and they store them. And then, when they want to have a baby, they'll defrost it and put it inside, your uterus. Well, if you've got 12 embryos, most people are not going to want to have 12 kids, right? And so, after that, you can make a decision to, some people will donate any embryos that they have left over. For people that want to get pregnant but aren't able to on their own. There's also, they do a lot of work with people, young people who are undergoing cancer treatment, because unfortunately some cancer treatments like chemotherapy and radiation therapy can damage your ability to get pregnant in the future. So they might meet with those people before they start their cancer treatments, and take their eggs or take part of their ovarian tissue or take their sperm and store it so that they're able to have genetic children in the future. Minimally invasive gynecological surgery is 2 extra years of basically doing specialized surgery, where it's like keyhole surgery. So instead of making a big cut on your belly, you're putting a camera inside the belly cavity or inside the uterus and operating, kind of with smaller instruments. Pediatric and adolescent medicine is, dealing with kids who have, gynecological concerns. So when I learn about all the things that can go wrong when you're developing, it's kind of crazy that anything actually ever goes right, and that's kind of the default. But people, can develop, and when they're a fetus, so when they're on the inside of the uterus, their uterus doesn't grow, and you don't know about it until they don't have a period when they're 15 or 16 or 17. Or you can have people who look like they're female, they have a normal, appearing vulva and vagina, but they actually are XY male genetic sex because of some hormone problems that happened, while they were inside the uterus. And so they deal with those kind of things and helping those people. And then complex family planning is, for either people that don't want to be pregnant or it's dangerous for them to be pregnant, they can't take necessarily traditional birth control because of significant health problems, or they're pregnant and they need to end the pregnancy for some reason. And so that's complex family planning. I picked OBGYN. Well, I remember I did my OBGYN rotation in my 3rd year of medical school, and I can remember starting my OBGYN rotation and being oh my God, why would anybody want to spend the rest of their life looking at vaginas? I can't think of anything worse. And then I'm here. So it's just one of those things where during medical school, you'll find something, that you'll love. And that's kind of what you end up doing. But, the things that I tell people, you have mainly healthy people, right? So unless you're dealing with, unless you're a gynecologist, a lot of people are coming to you for pregnancy or for preventive healthcare, or, they don't have a lot of like other medical problems going on. It's not like, like chronic disease, like a primary care doctor, that's all you're dealing with is like people, that have illnesses. You have longitudinal relationships with people, which is something that, I really liked. Like I have people that, I've been here long enough now that I've delivered like 3 of their babies, and now they're coming to see me because they're having bleeding problems, and I've been taking care of them for 10 years. And, I know their kids, and I know their partners, and I know their families, and that's really cool. You never are doing the same thing every day. There's so many different things that you can do, and so it kind of never gets boring for me. And then it's a really cool mix of medicine and surgery. So, on days when I'm bored because, or I feel like I'm like, oh, I can't talk to anybody else. I've like talked to too many people today. Then the next day I might be in the operating room and everybody's asleep and I don't have to talk to anybody. So it's kind of like a really nice mix of what we're doing. So like a typical week, now this is, I only do like half of my time is like clinical now and half of it is administrative, but this is what I did before I started doing more administrative time. So like on a Monday, I might be in the operating room. Tuesday, I might be in the clinic. Wednesday, I might be on like our labor and delivery floor. So I'm like delivering babies during the day. Thursday, I might be back in the clinic. Friday is currently my day off. So I always have a day off. And then about 2 weekends a month, I'm on call. And what do you think being on call means? Yep.
It just means that anything that goes on in the hospital that needs an OB-GYN, or they can send you a page, or I think literally like a call, and it's just like you have to come in and the expectation is like you're there, you can fix it. I'm guessing when you specifically say like L&D call, does that mean there's like a more specific call where someone's just there for dedicated labor and delivery emergencies?
So this is part of the thing, right? So we have and I say labor and delivery call, and I am covering everything. So and we take in-house call, meaning we're in the hospital for 24 hours. We don't go home for 24 hours. And I'm covering the emergency room. So if somebody comes in through the emergency room with a gynecological emergency, I'm covering like labor and delivery. I'm covering our OB/ED. I'm covering like the postpartum floor, which is people that have already delivered babies. I'm covering our antepartum floor, which is people that are still pregnant and they might be having problems. And then I'm covering like the gynecology, floors, so like anybody that's admitted with like a gynecological problem. But the issue is that for babies, if something's going wrong with a baby, you have about 5 minutes to intervene before there's brain damage. So most of the time, we're kind of like stood on or sat on labor and delivery because, things happen really, really quickly on labor and delivery. And then luckily, when I'm on call, because I'm working for 24 hours, I get the next day off. I get to sleep. So what's good and bad things about being an OBGYN? I put there, you have to love it, right? It can be really hard, and anything in medicine is, hard. One of the favorite things for anybody is it never gets old delivering a baby, right? When all of a sudden there's like, it's kind of like this theoretical thing, right? You know that there's a baby inside the uterus, but then all of a sudden there's a baby outside the uterus. And it's like, it's like an actual real life human being. And it's kind of like blows my mind every single time. I love to operate. I love the fact that, I joke with people that, somebody comes in with like abnormal bleeding, for example, and, you can give them some different medications to try and treat it. You can do like ultrasounds to see if there's like fibroids, which are like balls of muscle within the uterus that can cause bleeding problems. And, there's a certain number of medications. And then if none of those work, you cut it out. And then it's done, and they're not bleeding anymore. And that's super satisfying because it's like really definitive. Like it's not this thing like, You know, I can remember doing medicine, like general medicine rotation in medical school, and somebody coming in and saying to me, these blood pressure pills aren't the same as my old blood pressure pills. And I'm like, they're exactly the same. They're like, no, they're not. And I was just like, they're like a different color. And I was like, that's just because, you know, there's generic and there's, you know, brand name, right? So it's like, you know, you go to the grocery store and there's like Safeway chocolate and there's like Hershey's chocolate, right? So it's still chocolate. And he was like, no, I know it's not the same because my other blood pressure medications go away when I flush them down the toilet. And I'm just like, oh my God. And so that generally doesn't happen in OBGYN. People generally tend to do like what you want them to do. Like building, you know, relationships like we talked about. I like to teach, you know, so even if you're not teaching like students, right, you're teaching families, you're teaching, you know, people about their health. You're, you know, encouraging them to like, you know, be more empowered and to understand themselves better and make changes that can make themselves more healthy. You can customize what you do. I said about my friend who's doing, you know, just like vulva specialty. You know, there are some people that what we call OB hospitalists, and all they do is, you know, shift work where they're just on labor and delivery and they're just like there for safety and for emergencies or delivering babies. And so they don't do any outpatient, they don't do any, you know, operating room stuff. There's a lot that we don't know about in medicine, and, you know, things are changing all the time. Stuff that I learned in medical school, you know, 20 years ago is completely outdated. Stuff that I learned in residency 12 years ago is outdated. There's things that we were doing 3 years ago that now we're just like, that's stupid. And so you have to like be willing to learn all the time, and that's something I like, you know, not knowing things and like having to look it up, and that's exciting for me to learn things. So bad things. Malpractice. Have you heard about that? Do you know how often an OBGYN is likely to be sued, like in their career?
I don't know the exact stat, but isn't it the highest in all medical disciplines?
Yes.
So it's actually the second highest. The most sued is radiologists.
Really?
Yeah, the most sued is radiologists, but we get, or successfully sued, I would say, as radiologists. But when we get sued, we have to pay out a lot of money,
Yeah.
unfortunately.
Is it only for C-section deliveries, or what do you usually get sued?
A lot of it is related to babies, right? And so it's not necessarily for C-sections. It's because, so in most places in the US, it's up to age 18, but in some states it's up to age 21, that they can sue you for anything. So if they're like, you know, my kid got diagnosed with ADHD and I think it's related to the fact that, you know, he was stuck in the birth canal for a minute, and I'm going to sue you. They have up until the kid is 18 to do that. Now, they might not necessarily win, but you have to go through, you know, the whole process. And on average, OB-GYNs will be sued 4 times in their lifetime. I've been out for 12 years now, and I've been sued once. And they were asking for, guess how much they were asking for me or my insurance company to pay them?
I'm gonna guess over $300,000.
800
Yeah.
Over
2
$100,000.
million. 10 million. 20 million.
$15 million.
What?
You have to think of it as a person. So
Yep.
say they are concerned that something related to the birth is affecting that person for the rest of their life. And you remember what they said the cost of a life? Remember one of the doctors mentioned that? Yeah, at least 500,000 minimum. So it's like
Minimum.
minimum.
And then you add on pain and suffering.
Yeah.
I think it was Clinton who tried to pass like a cap on how much a doctor could get sued for. Did any of that sort of thing?
There are certain states that have what we call tort reforms, which they cap how much you can get.
I'm guessing no cap in OBGYN?
Well, no cap in the state of Washington. They did not get $15 million, don't worry. And my insurance company were willing to go to court. But I can tell you that the case happened, and if you want, I can tell you all about it. But the case happened in 2012, and it finally settled last year. So it was nearly 10 years. It was 10 years that we were kind of going back and forth about, if we were going to pay them anything, if we were going to go to court, and how much we were going to give them. So that's like really stressful. It's like I said, I'm getting old now. I'm working 24 hours in a row when we're busy, and I literally do not sleep for 24 hours, and I might have been up for 16 hours and there's an emergency, and now I have to do an emergency C-section, and I have to get this baby out in 2 minutes. That's crazy, right? I mean, think about if you had been up for 23 hours in a row, and then they ask you to drive a car backwards going around a corner. I mean, that's kind of what we're doing when we're operating. So you really have to be very skilled and spend a lot of time making sure that you're doing what you need to do. Political interference, we're in the state of Washington, thankfully. Seattle, it's liberal. But even the fact Swedish is affiliated with Providence, and so technically, there are certain restrictions on what we can do. We're not restricted on providing birth control. We're not restricted on, intervening if somebody needs a termination because of a life-threatening situation. But if somebody comes in and says, I'm pregnant, I don't want to be pregnant, we have to give them, information about where they can go, because technically I'm not allowed to do that on Swedish property. There's, places, I could talk about this forever, but, there are places, in Florida, right, where you can't, give trans-affirming care or, even talk about it. And, I am part of our gender-affirming surgical program, and so I take care of a lot of people who are, gender fluid, gender, non-binary, gender non-congruent. And, people come in and they, it's literally life-saving, right? They are depressed and, they've thought about, killing themselves because what they are on the inside doesn't match what they are on the outside. And, providing care for those people can literally be life-saving. And, that's kind of a good and a bad thing. The fact that I'm able to do it is amazing. And it's super rewarding. And the fact that some people can't get it, and there are whole places in this country where you can't get full scope care is really horrible. Social media. Who's heard about the baby in Georgia, the doctor in Georgia, the OBGYN in Georgia, there was what we call a shoulder dystocia, or the baby got stuck and the baby got decapitated? I know, it's horrible, right? And so there's a thing called a shoulder dystocia, which is where you're delivering a baby, right? The head is normally the biggest part. And for some reason, the shoulders are bigger. And when it's coming through the birth canal, the shoulder gets stuck behind the pubic bone. And you kind of have to do maneuvers, so you have to put your hands inside and twist the baby, or you have to kind of push down on the outside to try and get the shoulder underneath the pubic bone. And sometimes it's probably the thing that OBGYNs are most terrified of. Because, when I talked about the fact that you have about 5 minutes to get a baby out before there's brain damage or potential death, this is one of those situations, and 5 minutes is not a long time. And, if you can imagine that we're in a delivery room, and the labor and delivery room is down the, maybe just 4 doors down, but we still have to get that person out of that room into another room, get them over onto another bed, get them put to sleep, and, cut them open and get the baby out in less than 5 minutes, right? And that can be really difficult. And, so one of the things that unfortunately can happen is that sometimes we can't get the baby out in time. And sometimes the baby dies when that happens. And then it's about saving mom's life, right? And, because you can't just not take out a baby. And if they've already come out, if the head's already out of the birth canal, you kind of have to push it back up again in order to get it out. And sometimes that doesn't work. And if that doesn't work, there's no other choice but to separate, unfortunately, the baby. And we can't talk about what we do, right? So if you come to me as a patient and I operate on you and something, happens, whether it's my fault or not my fault, you can go and you can tell everybody that I did something wrong, and I can't talk about it at all. And, social media is, there's a lot of things that happen on social media. And, people are blaming, OBGYNs for a lot of things, and people just don't know the truth about what we do. And there's even people, like when I'm talking to my residents, like they didn't know that that is something that, and I'm going to touch wood, I've never had to do that ever. And I hope to never, ever have to do that, right? Yeah, exactly. But that is in order to save, people's lives. And I think that America isn't very good at, it's not the best in the world at maternal health, right? We know that, compared to Europe, for example, more women die during childbirth here than in other places. But it's still really good compared to places like rural India or rural Africa, go back 200 years. And, the life expectancy was, you go back 300 years and the life expectancy was about 30. That's not because people died at age 30. It's because so many people died while giving birth or as an infant that it when you look at the mean, if people survived childbirth, they would live till 70. And there's still places in the world where, 50% of women die during childbirth. It's a really dangerous thing to do. It happens so rarely here that people think that it should never happen. And even when, we're trying our absolute best, bad things can still happen. And it's really hard, if something happened to my baby because of something I did, I don't want to blame myself. How can I live with myself? It's much easier to blame the doctor. And that's one of the reasons why OB-GYNs get sued a lot, because it's much easier to blame somebody else, even when it's not our fault. And sometimes it is our fault. And so when it's bad, it's really bad. Right? I mean, when I have, somebody coming in and it's their first baby and they're super happy to have a baby and I do an ultrasound and there's no heartbeat and I have to tell them about that and I have to help them with that. Or I have somebody that comes in, for a, wellness visit and I do a pap test and it's abnormal and I have to tell them that they have cancer. I mean, that can be really horrible. One of the things that I will say, though, is that can honestly be although it's hard in the time, it could be one of the best things we do as well. Because if you have somebody that is, caring and compassionate and can help you through that and can get you set up with the right people and can help you navigate healthcare, which is really difficult, that's really, really rewarding. And I tell people that, being there when somebody's born and being there when someone's dying and making sure that those are happy events, those are some of the best gifts that you could ever give to a person in their lifetime. So although it can be really bad, it can also, you have to find the good parts of it. I don't think training's long enough, right? Even back when I trained, so we had the 80-hour work week restriction, which means that we're not supposed to work 80 hours. They'd literally just introduced it. And I was still working 120 hours a week regularly, which is crazy. It's not safe. But now, it's really strict, and most of the residents aren't working more than 70 hours a week, but it's still only 4 years. And so, a lot of the things that I learned, because I just spent hours and hours more training, there's not enough time in those 4 years. And so I think that, that's part of the issue is, why people are doing the mixed training is because they don't get enough surgical training during their residency, unfortunately. And then the other bad thing is that you have to know everything, because nobody else will deal with pregnant people. I have to deal with, when somebody comes in and they're pregnant and they're asthmatic, I have to manage their asthma. I have to manage their thyroid. I have to manage their diabetes. I have to manage their high blood pressure. So you kind of have to know a little bit about everything, because, there's lots of people that are just I don't take care of pregnant patients. Would I choose this again? Despite all of that? Yes. But that's what I say, you have to really love. It has to be something that you really, really love, to be able to put up with all the bad things, and make the good things good enough for you. So, what questions do you have?
Come on. Absolutely.
I think something that's come up a lot is like the culture in different specialties, and especially with OBGYN being such a historically female-dominated field and one of the few that has been that way for a long time. What do you really find people and the honestly community of doctors as a whole are like?
I think that that's a really good question. So there are, historically, it was a very male-dominated specialty. So it's only been, probably in the past 15 years, 15, 20 years that it's been predominantly female. And about 70% of graduating residents, 75% of graduating residents from OBGYN residencies are female. I would say that there's a lot more collaboration. There's a lot less, kind of one-upmanship than what I've seen like in surgical specialties. There's a lot more like supportiveness, but there's a lot of sexism built into medicine. And like, for example, I had my baby in residency and I got told, well, you're going to be out for 6 weeks. You have to make up that call. And I'm like, I'm not going to be on vacation. Like, I've just had a freaking surgery. My baby was preterm and breech, right? And they're like, well, breech means butt first, so I couldn't have a normal delivery. And so I had to have a C-section. And I'm like recovering from a C-section while trying to take care of a newborn baby that's in the NICU. And they're talking to me about the fact that I have to make up time because I'm missing call. And so, there's not a lot of like built-in support for things like that. It's definitely getting better, but it really depends on where you are. And then there's, I think that the good things about it is that a lot of, women want to come and see women. And so, we're definitely, busy, especially groups that, have primarily like women doctors within them. But there's also some like really inherent, I think, sexism within women. And, so I've seen, like, one of my partners is an older white male. He's fantastic. But, he'll say something and I'll be like, well, I disagree with that because, things have changed a little bit since, maybe that was the case and this is the new research. And the patients will be like, well, you have to ask Dr. Loudermilk what Dr. Loudermilk thinks. I'm not going to trust you. And so there's still a lot of people who, really think that a doctor is a white male. I have many, many times I've introduced myself as a doctor and, they're like, the patient will be like, oh, so when's my doctor going to come and see me? Or are you the nurse? Or, what, you do surgery? And I'm like, yep. So.
I think it's really interesting that you mentioned that because I feel like in our generation, I feel like there's a more preference towards female OBGYNs, So I think that's really important that you mentioned that because times are changing and I think our generation has a better idea of what a doctor looks like now, And so I think, having more women like you that are in this field kind of shows that.
It does, and it doesn't, unfortunately. I went to pick up my kid from school like 5 years ago, and I was wearing scrubs because I just left, the hospital. And there was a kid that was like, oh, are you a nurse? Like, and, he's like a kid. And then one of the other kids was like, no, she's a doctor dummy because nurses wear nurses' hats. And I was like, no, they actually don't anymore, but okay. So that's awesome. But yes, I think that times are changing. Yeah. And it's hard, a lot of obstetrics and gynecology is based on, there's not a lot of like, women weren't included in research and pregnant women definitely weren't included in research. In fact, there was a federal protection that said that pregnant women could not participate in research. That's only just been lifted in the past like couple of years. Like after COVID when, lots of pregnant women were getting really sick or dying from COVID, and there were still people that wouldn't give, the vaccine to pregnant people because they weren't included in the research studies. And, a lot of the things that we thought we knew, were really based on kind of like very racist and sexist like misperceptions, or they were based on studies that were done, on men and are really not relevant to women because we have completely different physiology. And so that's another thing that's, kind of difficult, but, like I said, stuff that we thought we knew is absolutely not true.
Kind of also following up on that, like learning so much, how do you see different like technologies and especially the rise of AI and minimally invasive surgeries and all those things? Where do you see all of that going?
Yeah, I think that, so this is another thing that's, there's, a lot of sexism within it. So, and I could literally talk for hours about this, but so for example, right, if I'm a urologist and I'm doing a biopsy on a penis, I get paid twice as much as what me as a gynecologist gets paid for doing a biopsy on a vagina. It's kind of the same, like, analogous thing. If I'm a urologist and I'm doing a biopsy on a vagina, I get paid more than me as a gynecologist doing a biopsy on a vagina, right? For pregnancy care, I get paid it's called a global fee, meaning I don't get paid anything until that person's delivered. And it's one amount, which is on average about $1,500 for the entire 40 weeks of prenatal care, for the delivery, even if she has a C-section, even if she has like a horrible delivery, and all the postpartum care, and for 12 weeks after delivery. That's how much, we make. And so there's actually, reimbursement, insurance reimbursement is really low. And so people are really reluctant to invest in technology in women's healthcare because it doesn't reimburse very well. Insurance doesn't cover it very well. And so we're way behind the times for, technological advances. So I don't know is the answer, but I don't know that it's going to get a lot better unless insurance changes.
Sorry.
No, ask as many as you want.
With all of this, like you've touched a lot on the positives and a lot of the negatives with all that thing, people constantly coming after you, social media, lawsuits, and all of that. What do you think is the thing that really keeps, you especially and a lot of your colleagues, in love with this field?
It's the people. Yeah. It's the relationships and the people. You're not just, seeing them one day and then saying goodbye. It's you're, really getting involved in their lives. I can tell you about a patient that I had, recently who, I've taken care of her for 3 of her babies. And she was coming to see me for a preventive health visit. And she was just like, my mum, I just found out that my mum had breast cancer when I was younger because she's just been diagnosed with breast cancer again. And I'm like, is it in the same breast? And how old is she? And, it turns out that she was actually really young when she had her first breast cancer. She'd never really talked about it before because her mum hadn't told her, which is like not uncommon in, older, populations, that they don't tell their kids about things like that, right? And I was just like, well, there might be like a genetic reason why, she has a breast cancer. Do you know if she's been tested? And she was like, no, she doesn't want to be tested. And I was like, would you like to be tested? And she was like, well, yeah, because I'm kind of scared. And so I sent her for genetic testing, and it turns out she didn't have the mutation that causes breast cancer, but she actually had something called Lynch syndrome, which can cause cancer of the bowels and cancer of the uterus. So now she's like, thinking about, should she get her uterus removed? Should she get her ovaries removed? What's that going to look like for, what's that going to look like for, being menopausal, like at age 40? Like, what's her long-term, like, heart disease risk? Like, and literally I spent, just 45 minutes talking with her, and she was just like, how am I supposed to tell my kids? When am I supposed to tell my kids? Like, what if I've passed this on to my kids? And so, it's like just the fact that, like, I know her, like, really, really well, and, that we just, and she was, at the end of it, she was like, I'm so grateful, my family potentially, my cousins are getting tested for this, and this might save, somebody from ever getting cancer. And it really is stories like that, or I had a patient who had had a previous pregnancy loss, like her baby died at like 28 weeks. And, she was seeing me for her pregnancy, and something just didn't seem right. And like everything was kind of okay, but it just different from, what it was, before. And I was just like, look, I just think I want to just put you in the hospital just overnight. Let's just see what happens. And she got sick really, really quickly. And if she hadn't have been in the hospital, either her or her baby might have died. And she had a healthy baby, and she's healthy. And it's just, being able to do that, right? Being able to really impact people's lives, it honestly is amazing. And it makes up for, as long as you love what you do, it makes up for everything else.
Again, we thank you for just being you and coming out and sharing your experiences. Thank you for coming out.
Absolutely.
Thank you.
And I didn't put them in because I